content of this podcast is provided for educational purposes only. It is not legal advice, and it is not medical advice. Case facts, verdict information, and procedural history are drawn from publicly available court documents. Clinical roles, expert witnesses, and the venue of the proceedings are anonymized. The opinions provided are my own and are not statement of medical or legal fact. If you have any questions, consult with your attorney or risk management officer.
In episode 1, we walked through the clinical record of this case from the first emergency department visit through the admission and the patient's death. Before we step into episode 2, I want to flag one teaching point to carry with you for the rest of the season. The patient in this case had undergone a transmastoid resection of an acoustic neuroma years before this case. That prior surgery matters clinically for two reasons. First, a reconstructed mastoid with bone wax, an autologous fat graft, and a collagen-based dural repair is a recognized potential site for delayed cerebrospinal fluid leak and for bacterial meningitis in the clinician-facing literature I reviewed for this case. Second, a patient with that surgical history can present with bacterial meningitis in a way that doesn't look like the textbook picture most of us were trained on. The constellation of findings, the cardinal four signs we walked through in episode 1, can be muted or sequential rather than simultaneous. That is an important teaching point, and it is the clinical lens I want you to hold on to as we move into the expert witnesses and the legal case. This episode is squarely on the expert witnesses, the competing causation theories, and the deposition record. The broader legal architecture of the trial and the post-trial proceedings is deferred to episode 3. This is On the Record. I am Michael Coleman. This is season 5, episode 2.
Episode 1 ended with the patient's death approximately 24 hours after the admission from the third emergency department visit, and with an autopsy that confirmed acute pneumococcal meningitis with ventriculitis. The dispute at trial was not over the diagnosis. The dispute was over how the infection evolved and when it became identifiable. Two competing theories framed the entire case. The plaintiff's theory, carried by the plaintiff's case-in-chief experts, was that the patient had a slow leak from a low-grade infected collection at the reconstructed mastoid site into the subarachnoid space. On that theory, the leak was progressing over the preceding day or more, and by the morning of the second emergency department visit, the patient was already suffering from a progressive, treatable bacterial meningitis that was identifiable on the data in the chart. The plaintiff's position was that the last meaningful window to draw cultures, perform a lumbar puncture, and start empiric ceftriaxone and vancomycin closed around midday on the day of the second visit. The defense's lead theory, carried by the defense infectious disease expert, was that the patient had a walled-off collection at the old surgical bed that catastrophically ruptured into the subarachnoid space while she was being observed in the emergency department on the second visit. On that theory, the rupture itself was the event that explained the patient's transient improvement in the ED. Decompression of the collection produced symptomatic relief, which the treating physician reasonably took as reassurance and used as a basis to discharge her home. The defense position was that the rupture was unsurvivable from the moment it occurred, and that no lumbar puncture and no antibiotics started at the morning visit would have changed the outcome.
Those two positions define the clinical dispute in the record. Each side is effectively using its own timeline to define the standard of care. If the plaintiff's slow leak timeline is accepted, there was enough objective data in the chart at the second visit that a reasonably prudent emergency physician was required to perform a lumbar puncture before discharge, and a breach of that standard caused the outcome. If the defense's ruptured collection timeline is accepted, the event that produced clinically detectable meningitis had not yet occurred when the discharge decision was made, and no intervention at that visit could have changed the outcome. The mechanism fight is not an abstract microbiology exercise. It is the fight that anchors where on the disease timeline the patient was sitting at the moment of the discharge decision, and that is what determines the answer to the standard of care question.
The plaintiff's retained experts, as they appear in the trial court record, fell into three categories. 2 case-in-chief experts addressed the standard of care and causation. A third expert was designated in rebuttal posture only. A fourth expert was withdrawn before trial.
The first case-in-chief expert was boarded in emergency medicine, internal medicine, and infectious disease. His testimony covered both the standard of care at the second emergency department visit and the causation timeline. The second case-in-chief expert was an infectious disease specialist whose testimony was directed primarily at causation and the natural history of pneumococcal meningitis. The rebuttal expert was a neurosurgeon retained specifically to respond to the defense neurosurgeon and to the defense infectious disease expert on the question of meningeal enhancement and the acoustic neuroma repair. The order on motions in limine addressed a defense motion to limit cumulative standard of care testimony. For the physicians listening who do not work in law, a motion in limine is a pretrial request to the judge to rule on what evidence or testimony will be allowed at trial before the jury ever hears it. A cumulative or duplicative testimony motion is a specific kind of in limine motion that asks the court to prevent a party from calling multiple experts to say the same thing on the same issue. Courts grant these motions for reasons of trial efficiency and to prevent a jury from being swayed by sheer volume of witnesses rather than the substance of what each witness has to say. In practical terms, it forces each side to pick its cleanest witness per issue. In this case, the court's ruling permitted the plaintiff to present this expert on the standard of care question in the case-in-chief and limited the infectious disease expert to causation.
The standard of care opinion advanced by the plaintiff's lead expert in substance was that a reasonably prudent emergency physician confronted with the constellation of data points present at the second visit, the return within 24 hours, the severe pain, the prior fever, the white blood cell count of 19,000 with 92% neutrophils, and the cervical MRI flagged for meningeal enhancement with a recommendation for clinical correlation, was required under the standard of care to perform a lumbar puncture and to have empiric ceftriaxone and vancomycin infusing by approximately noon on the day of that visit. That time to antibiotics opinion is a specific clock-on-the-wall argument. It does not rest on a diffuse should-have-done-more framing. It rests on the proposition that there was a window, measurable in hours, in which the standard of care intervention could have changed the outcome, and that the window closed while the patient was being discharged home. I want to slow down on one specific clinical point from the radiology impression because it is a place where I had to correct my own mental model working through this record. The cervical MRI impression flagged meningeal enhancement and recommended a lumbar puncture. The impression also contained a parenthetical observation that the appearance could also be a sequela of a previous lumbar puncture. That parenthetical is real, and I do not want to hide it from the audience. The teaching point I want to share is that the parenthetical was not as clear as it looked on first read. A careful review suggests the radiologist was describing a pattern that would be expected after a recent lumbar puncture, not a lumbar puncture from years earlier. The patient's prior lumbar puncture was approximately 5 years before these presentations. That distinction is important because it changes how this should be weighed at the bedside. The plaintiff's rebuttal expert addressed that point directly and testified that the published imaging literature on transient meningeal enhancement after a lumbar puncture describes a duration measured in days to weeks, at most a month or so, not 5 years.
There is one more piece of the plaintiff's expert history that deserves a moment of attention, because it matters for a teaching point later in the episode. The plaintiff had originally designated a fourth expert, a critical care physician, to offer additional causation opinions. In the course of discovery, that expert's testimony turned out to be inconsistent with the rest of the plaintiff's causation theory, specifically on the characterization of the pathology at autopsy. The plaintiff withdrew that expert before trial rather than walk an internal inconsistency in front of the jury.
The defense retained 5 experts whose opinions appear in the trial court record. The defense infectious disease expert offered the opinion that the rupture into the subarachnoid space occurred in the mid-morning during the emergency department observation on the second visit, and that the rupture was the triggering event for clinically detectable meningitis. A sudden, catastrophic event he characterized as unsurvivable. However, the defense neuroradiologist offered the competing opinion that the rupture was not sudden, but rather a slow, gradual leak developing over the preceding 24 to 48 hours. A mechanism he described using a toothpaste tube analogy. The defense neurosurgeon offered a hybrid position that attempted to bridge the infectious disease expert's sudden rupture timeline with the neuroradiologist's slow leak anatomy. The defense emergency medicine expert offered a standard of care opinion that the morning physician's clinical reasoning was reasonable, and that a 6-hour emergency department observation window of the kind reflected in the chart met the standard of care. The defense neurology expert offered the opinion that the acoustic neuroma surgery had severed the nerve endings responsible for pain sensation in the posterior fossa, and that this explained why the patient did not experience the severe headache that would have accompanied a typical rupture.
A few observations about the defense expert lineup. The severed nerve endings theory is a defense theory grounded in the prior surgical anatomy. The plaintiff's rebuttal expert addressed it directly and testified that in his operative experience, he had not encountered evidence of posterior fossa sensation loss of the kind the defense was describing. Both positions are in the record. I am going to leave it to the audience to weigh them. The 6-hour ED observation window from the defense emergency medicine expert is also a specific number to hold onto. It is the anchor the defense used to argue that the morning physician gave the patient adequate time for clinical deterioration to become evident within the emergency department, and that no such deterioration occurred within that window. One observation about the defense experts as a group: the defense infectious disease experts' sudden rupture timeline and the defense neuroradiologist's slow leak timeline are not the same timeline. The defense neurosurgeon's hybrid position was the defense's attempt to bridge them. I am describing the expert record as it existed going into trial, how the trial court analyzed the relationship between those two timelines, and what the trial court did with it in a written order will be discussed later.
Beyond the timing dispute, there was a separate dispute between the parties about the correct pathological characterization of the autopsy findings.
The empyema versus abscess dispute is the kind of pathology debate that sounds technical, but is actually doing heavy lifting on the causation question. If the autopsy material represented a walled-off abscess that catastrophically ruptured while the patient was in the ER, the defense timeline is supported, explaining both her temporary relief from pain due to decompression and why the resulting instant meningitis was, on the defense view, inevitably fatal regardless of earlier treatment. If the material represented an empyema, a low-grade infection seated in a pre-existing surgical space, that slowly leaked, and if the material found at autopsy was actually an organized collection of surgical remnants, the plaintiff timeline is supported, meaning the patient was already suffering from progressive, treatable bacterial meningitis before she walked into the emergency department at the second visit. The autopsy report itself confirmed the diagnosis of acute bacterial meningitis with ventriculitis and also described purulent material at the old surgical bed in addition to the meningeal findings. The plaintiff's rebuttal, carried by the plaintiff's neurosurgery rebuttal expert, was an attempt to reinterpret that specific autopsy finding through a different frame, arguing that what the pathologist was looking at in the old surgical bed was, in substantial part, leftover surgical debris from the acoustic neuroma repair, including fat graft material, collagen-based dural substitute, and organized remnants rather than true pus from a ruptured abscess. That is the core of the pathology dispute in the record. Both sides were reading the same autopsy material through different frames.
The emergency room physician was deposed approximately 1 year before trial. In her sworn testimony, she described in detail the physical examination she recalled performing, the cervical palpation, the assessment of range of motion in multiple planes, the abdominal examination, the cardiopulmonary examination, the neurologic screen, and the extremity examination. Plaintiff's counsel then asked whether everything she had described in that deposition was reflected in the chart. Her response was that we do not always document every physical exam finding.
That is the structural problem the defense walked into trial with, and it is the reason I want to emphasize one narrow clinical teaching point. When you are at the bedside and you are performing a targeted examination because you have a specific concern on your differential, expand on the pertinent examination points in your note. If you checked for meningeal signs, then meningeal disease was on your radar at that moment. And if it was on your radar, take the time to explain exactly what you examined, what you found, and how those findings played into your decision-making. The single word, none, or the three-word phrase, no meningeal signs, does not do that work. A charted note that reads, neck supple through full flexion and extension without pain or limitation, no Koenig or Brudzinski elicited on provocative maneuvers, no photophobia or phonophobia reproducible at the bedside. Meningeal process considered less likely based on these specific findings. That note defends the decision. The three-word version does not.
The admitting hospitalist, who assumed care of the patient following the third emergency department visit, authored a consultation and admission note. And one sentence from the assessment section of that note became the subject of extended deposition examination of the plaintiff's infectious disease and standard of care experts. The note was marked as a deposition exhibit, and its language was read into the record verbatim during both depositions.
The admitting hospitalist's first assessment item read, in quoted text from the record, quote, acute bacterial meningitis due to streptococcus pneumonia. The patient was afebrile during her pre-hospital course, which is known to be associated with a poor prognosis and high risk of death. End quote. I want to be precise about what that sentence does and does not say. It states the diagnosis. It states one specific observation. The patient was afebrile during her pre-hospital course, and it connects that observation to a prognostic statement drawn from the medical literature. An afebrile course in bacterial meningitis is associated with a poor prognosis and a high risk of death. It is a prognostic marker statement.
I want to explain the evidentiary framework around that sentence because it sits on one of the more contested lines in civil procedure. In most jurisdictions, there is a distinction between a fact witness and an expert witness. A treating physician is, by default, a fact witness. The treating physician's records are admissible as to what the physician observed about the patient, what diagnoses the physician made, what treatment the physician provided, and what the physician's reasoning was at the time for those observations, diagnoses, and treatments. That is the permissible scope of treating physician testimony without a formal expert designation under the civil rules. But the civil rules also require that any witness who is going to offer opinion testimony based on specialized knowledge, expert testimony, be disclosed in advance with the substance of the opinions and the basis for them so that the opposing party has a fair opportunity to depose the expert and prepare cross-examination.
The sentence in the admitting hospitalist's note is a fact witness entry, a treating physician's written assessment at the time of admission. But the prognostic implication of that sentence, that an afebrile course in pneumococcal meningitis is associated with a poor prognosis and a high risk of death, is the kind of generalized medical literature opinion that normally belongs in the expert witness lane. When a fact witness entry in the chart carries an expert witness implication into a trial, the procedural question is whether the opposing party had a clean opportunity through formal discovery channels to prepare a rebuttal from its own experts. My read of the record is that the argument here is more of a legal one than a medical one. The plaintiff appears to have been in the position of trying to rebut at trial a prognostic statement embedded in a treating physician's note. A statement that, if taken at face value, would suggest an extremely poor prognosis at the third emergency department visit, regardless of what happened at the earlier visits. That is a hard thing to rebut without a full expert witness runway behind it.
The civil rules divide testimony into two categories. Fact witnesses can tell the jury what they saw and what they did. Expert witnesses can tell the jury what something means. The rules require expert opinions to be disclosed in advance, in writing, with the substance of the opinion and the basis for it, so that the other side has a fair chance to prepare a response. That is the whole point of expert disclosure. It prevents trial by ambush. When a treating physician writes a sentence in a chart that states a medical literature conclusion, like, "This finding is associated with a poor prognosis and a high risk of death," that sentence is doing expert witness work inside a fact witness document. The other side did not have a chance to depose that physician as an expert on that specific literature-based opinion, and did not have advance notice that the sentence would carry the weight of expert testimony at trial. In a malpractice case, where the jury is being asked to decide contested medical questions they have no independent background in, that matters. It affects what the jury hears, what the other side can cross-examine, and how much weight the sentence can fairly carry. It is one of the reasons the fact witness/expert witness line is fought over so hard in these cases.
So, no, we know the stance of our sides in this case. The plaintiff is alleging a slow leak from this surgical bed that should have been diagnosed during the second visit, and by failing to perform the lumbar puncture or administer antibiotics at that time, the patient died. So they have established their standard, breach, and causation. The defense alleges that the patient had an abscess form in this potential space in the surgical bed. They suggest that while it was a walled-off infection, the patient had some symptoms, but not characteristic symptoms of meningitis. They allege that even if a lumbar puncture had been performed, it would likely not have shown meningitis, or it would not have changed the clinical outcome. They allege the abscess underwent rupture while the patient was in the emergency room, and that is why the patient had transient improvement in her neck exam that reassured the physician. That also explains why the patient had such a rapid decline at home, as the significant bacterial load was injected into the subarachnoid space. So the defense has established their standard. They are more or less saying that the question of whether there was a breach or not is irrelevant because it did not lead to the outcome. The defense alleges the outcome was due to the disease process, which was the ruptured abscess, and that not treatment offered during this emergency room visit would have been able to alter the outcome. So the defense is willing to concede breach but not causation. It's also important to see how the autopsy report is used by both sides. The defense needs it to support an abscess, and the plaintiff wants it to support an empyema. The defense, in the final episode of this case, will try to have select images from the autopsy shown in court to illustrate and support their theory of an abscess that ruptured catastrophically. That is the expert and deposition record of this case as it stood going into the final phase of the trial. Clinical mechanism, plaintiff experts, defense experts, pathology dispute, documentation concession, and the admitting hospitalist's note. Episode 3 is where the verdict, the post-trial fight, and the story of what the defense did with an autopsy record that was supposed to have been produced in discovery.
This has been On the Record. Season 5, Episode 2. The Charted Defense is hosted by Michael Coleman, MD. Sources for this episode are listed in the show notes. The content is for educational purposes only. It is not legal advice. It is not medical advice. The content of On the Record is provided for educational purposes only. It is not legal advice, and it is not medical advice. Case facts, verdict information, and procedural history are drawn from publicly available court documents. Clinical roles, expert witnesses, and the venue of the proceedings are anonymized. The opinions presented in the material are mine and are not statement of medical or legal facts.
Under the dark, under the day, 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 I'm forgiven. Under the day, I'm gonna see, I'm gonna see, I'm gonna be, I'm gonna see, I'm gonna see, I'm gonna be tonight. I'm taking time, I'm taking time, I'm taking time, I'm taking time, I'm taking time. Under the day,